like to welcome everybody to the AO Fireside series, and thanks to Mitch Bernstein and Brett Chris to organize these things. We are on a continuous series. The topic tonight will be distal radius fractures. I'm Bertrand Perry from Vancouver. We have Jonah Davies with us from Harborview in Washington, and Amit Gupta from Louisville, both with lots of experience in hand and wrist. I will moderate the session. The format tonight I'll get to in a minute. Let's just go on to the next slide. How can I move this forward? This is not, there we go. So here we are, faculty, photo shots of us. We have really no disclosures that have any conflict with this talk tonight. The agenda tonight will cover about 90 minutes. We're hopeful to not be a minute over. If we're shorter, all the best. I'm going to go over some objectives for 5 minutes, give you a top 10 priority things in wrist fractures that may be beneficial, and we'll open the panel for discussion during the cases. We will then essentially cover 3 cases over an hour between Dr. Gupta and Davies. If we have time, I'll have a short paper presentation on some recent evidence-based medicine, and then we will wrap up. The learning objectives tonight are listed here. One, to describe common articular patterns, recognize predictors of fracture instability, perform safe application of plates designed for distal radius, discuss surgical indications for lower demand patients, define surgical priorities and strategies when treating these fractures, and establish some postoperative protocols. So I'm going to start right now in a short overview of distal radius top 10. It's not going to be an exhaustive review. It's really just to set the tone for some topics to talk about tonight. Topic number, first issue of priorities, understand the intra-articular patterns. They are fairly reproducible. Essentially, there is a sagittal split that will split the lunate from the scaphoid facet, and that can be anywhere in that radial ulnar direction. So it can split the lunate facet in half or the scaphoid facet in half, but it is somewhere in that direction. And finally, a coronal split that divides the lunate and facet into both volar and dorsal fragments. This is what it would look like, and typically that volar ulnar fragment goes into extension. The problem is how to reduce that. If you apply more traction on the wrist, the volar ligaments typically worsen that extension deformity, and something typically has to be done manually to take it out of extension. This is a joystick technique where K-wires are inserted on the volar side, and under fluoroscopic control, it's extended, and the K-wires can be put through dorsally. This is an older case, but there's other tricks we can use, and we can expand on that later on. This is a picture, an X-ray post-op of a volar lunate facet fragment. It's obviously not reduced. These patients tend to have problems as the fracture of the lunate facet tends to collapse in the lunate facet and can cause pain and limitation of range of motion. Instability is a very difficult concept to understand. It's based on a lot of soft parameters. LaFontaine, in his critical paper, listed a whole bunch of parameters, including comminution, bone quality, initial displacement, intra-articular involvement, loss or reduction of the volar cortex, and associated ulnar fracture. Now, these are all come together, the package, but probably initial displacement and bone quality are 2 biggest factors leading to instability. And it often takes time in one's practice to get a sense of what's truly unstable and not. Here's an example of a patient who's 55 years old, comes in with all these parameters we talked about: significant initial displacement, intra-articular extension, dorsal comminution, bone quality, hard to assess here, but doesn't appear to be too bad. Post-reduction is here. Perhaps not the best placed wrist position in this flexed wrist. Reduction doesn't look too bad. It's surely still not acceptable, but more importantly, there's a grossly unstable fracture that certainly needs something more than a cast mobilization to maintain. Understand the volar plate you're going to use. There's so many in the market today. They have variations of the nominal angle of the fixed angle. Some of are fixed. Some are designed to be placed more distally. Some are designed to be placed more proximally. You should understand the place that you have. And if you're ever going to use indirect reduction techniques, it's good to understand what are the nominal angles of your fixed angle screws. Remember these distal screws to keep them short. They're not bicortical. And consideration for pegs may be at hand, as the pegs rarely have a sharp tip. So if you are indeed too long, you won't be causing tendon irritation. The watershed line is indeed the most distal part of the distal radius. It's the most volar portion of the distal radius. It was coined by Orbe in 2005. We've come to understand this critically now, that if a plate is applied distal to this line, that your chance of flexure tendon ruptures goes up dramatically, especially if that volar tilt is not corrected. So if your plate's placed distally and your volar tilt's not corrected, you have some element of dorsal tilt, the tendons can fray in this area. So beware of the watershed line, understand where it's at. Here's a bone model of that line, the blue side being on the lunate facet side and the green on the scaphoid facet side. If you look at this, it matches the shape of most distal radius plates. For newbies with distal radius plates, they'll often put it backwards because it looks more like a radial inclination if you put it backwards, but the plate is designed to be more proximally on the radial side. Also remember, the most common tendon rupture is the flexor pollicis longus tendon, and it travels right in the center of the radius right here. On the radial side of that, there's really nothing left other than FCR, which rarely gets a problem with tendon ruptures. So understand where that line is when you're doing a case. There are the 4 twos that I have when a volar plate might not work for your case: 2 distal, 2 radial, 2 dorsal, and 2 bad. Here's an example of 2 distal. Very small lunate facet fragment. We can elaborate that on later, but ultimately usually standard plates don't work for this. Here's another example of a very small facet fragment, and there are plates designed to be placed more distally. Understand that even if they're designed to be placed past the watershed, you may still have to counsel the patient on the need for hardware removal sometime early in the postoperative course. Here's 2 radial. Our volar plates that we have designed right now do not offer much support for scaphoid facet impaction. Consider alternative methods, a radial column plate or K-wires to suspend that scaphoid facet impaction. 2 dorsal, here's a fracture dislocation case that's always very unstable and probably the #1 indication for spanning plate. Volar plates don't work well for this, and obviously the ones that are so bad that you really can't reconstruct using standard hardware, and you may consider bridge plating with or without supplemental volar plate. Here's an example of a case with a plate removed. Radial length, probably the most important parameter with respect to pain. So if you look at patients that have pain at 1 year follow-up, the most important parameter that is not corrected is length of the radius. So they have a positive ulnar variance. So if you're going to try to fix something in your wrist fractures, make sure that the length is corrected. Low demand patient, there's lots of data that's come out about that right now. I don't think it's defined by age as much as it is by demand. Low demand patients probably do as well with non-operative treatment, and you don't run into complications of surgery. There are some indications for operating them, and understanding if you do fix low demand patients, there are some small advantages of operating them, and we'll get back to that later on. Fingers, fingers, fingers. A bad wrist with good fingers is better than a good wrist with bad fingers. So when you're seeing these patients in follow-up, don't stare at the x-rays as much as you do look at their fingers. Make sure they have good digital motion. CRPS is a bad problem, and it's very difficult to treat. Ulnar wrist pain is very common, can be related to impaction or drudge instability. Remember, most patients, this ulnar-sided wrist pain does improve by a year. So take your time before you decide to intervene and treat. So again, here are the top 10. We'll come back to this later on if we have to. But now I'd like to turn this over. There will be a recording, by the way, of this on the YouTube, and you'll be sent a link. I'd like to turn this over to Dr. Gupta's case, and we can then interact. There is a Q&A box at the bottom of all Zooms. We're going to leave that open for the question section. There are over 600 people registered for this fireside. Typically, a half to a third of those register and actually attend. So there are a lot of people online. We'll try to do our best to answer your questions. So Amit, over to you.
Thanks, Bert, and thanks for including me in this fireside. Basically, let me get to the back to the. So this is expanding on what Dr. Perry talked about. One of the points of his 10 things. So this is the Volar ulnar fragment, and I'll expand on this because I find this is one of the big challenges that face people who are treating this problem. So here's a case. This patient fell off a back of a truck, and he comes with this injury. So what can we do about this? So what we see here is that he's got a large fragment, which is volar ulnar, and it's got the whole of the corpus along with it. And the whole thing is shifted volarly. So now basically you have to reduce this and support this, buttress this on the volar ulnar side. So this was then this patient was treated elsewhere. And
before you can you go back to that just before?
Yeah. Mm-hmm.
So for these, I think sometimes we have practices that are very specialized and we go sort of very quickly in the details. But
yeah,
for this type of patient, are you routinely getting post-reduction CTs after a closed reduction? Do you get a CT before and then do a reduction? What's your sort of protocol for these types of injuries?
I would get a CT. They usually, if they're reduced, I'll get a CT of the wrist post-reduction.
And what do you look for? Like what would change your surgical management? I know this patient's treated elsewhere, but just so we can learn from the masters, so what would change your?
So what you look for that whether that split that Dr. Perry talked about, the ulnar-sided split, if there is any central depression, and what the geometry of the ulnar-volar fragment is. And I'll expand on this a little bit later when I show the other slides, which will show that this ulnar-volar fragment is usually like a boomerang fragment, and it's coming from the ulnar side and the volar side. So it's like a boomerang segment, and you have to, and it has the short radiolunate ligament attached to it and the lunate. So it carries the whole of the corpus with it. So it's very important to put this back and thereby stabilize the corpus. Otherwise, it'll tend to drift out. And, it's like simple monoblock volar fixation sometimes on its own may not do the trick. So I'm looking for the geometry of the distal radius in all its dimensions. If there is any styloid fragment, if there is any central depression, and what is the anatomy of the ulnar volar fragment.
Dr. Gupta, have you had much success with closed reduction of this? I mean, we reduced everything in the merge. Do you think that this is going to stay if we pull on it? I mean, if it looks just like this after a closed reduction, would you attempt again pending surgery, or would you just assume this is going to be 100% surgical?
This is a very unstable fracture and will shift volarly whatever you do. You can extend it and try to hold it in extension. But in my experience, these type of fractures will not stay. You have to put some buttress fragment or compress the volar ulnar fragment, yes.
I think your point is taken that when we talk about indications for plate fixation, this is probably the only fracture that has a 100% indication for volar plate fixation. There's really no value in K-wires, X-fix, cast mobilization. You'd agree this is an operative case 100% of the time.
Totally. And this particular fragment on this X-ray is fairly large,
yes.
But as you've shown in your other X-rays, in your cases, they can be of various shapes. They can be very small fragment, which you may not appreciate unless you do a CT scan, and it may be fooled by looking at a plain X-ray showing that it's just a straightforward volar fracture.
So the CT scan, Ben, I echo what you just said. I don't obtain CT scans all the time, but the central impaction on these fractures can be very misleading, and you seem to reduce the volar piece, but the lunate facet falls into this hole and ultimately it crumbles, especially if that piece is smaller. So I
Right.
agree. This would be a case that CT scan would nearly be a routine.
Correct. So as you can see, you can appreciate that there are multiple fragments in this fracture. So I think a CT scan would be appropriate. However, that was not done, and the patient underwent this fixation. So it seems reduced. Shona?
I mean, at first glance, it looks like they thought the wrist was, volar, so they put a buttress plate volarly to try to lift that up. When I look at, obviously we've spent time looking at those X-rays, but the cluster of screws is on the radial side. There's nothing supporting that ulnar fragment. And so although it may look reduced, I would suspect actually if we got better imaging, it may be not fully reduced already and it's trending in that direction. And so, I'd worry about this escaping that buttress plate. There's a tiny little bit of plate maybe buttressing that fragment, but there's no screws, there's nothing stable. So I would worry that that's gonna just run away and redislocate.
Well, the patient came in for follow-up at 3 weeks, and this is what has happened. So as Dr. Davis said, this is very embarrassing, and it's not, it has happened to me. I must confess that, I've had situations where these kind of things happen. And it's very embarrassing at 3 weeks when you have escape like this. So this is the point that the patient was sent to us, and that's how we got it.
So you get
this,
that. So basically, the problem when you say is it escape, is it so? This is not the AP view that corresponds with this lateral. No. Okay.
This is sorry. Yeah. Here's the AP view.
So the question is, was that lunate facet fragment, that little piece, it looked like was it a segmental piece? In other words, it looked like initially it went all the way across to the scaphoid facet. Do you think it's just a separate piece that came out of that area? Because ultimately, it's hard to know, right? I mean,
well, so here's the CT, and this shows it's basically the monoblock volar fixation is holding, but the small fragment is escaped out with the lunate. And so this is that small fragment that I was talking about, is escaped out from, and the screws are probably proximal to that fragment.
Right.
So this
and
is the.
Yeah, you can see, Bert, what you're talking about is that fragment is split.
Yes.
And so it does look like, and that's what I was trying to explain, that the plate was maybe covering, 1 or 2 millimeters of this fragment, but not enough to really truly buttress it. And this is a buttress type of an injury or a partial articular on that side. So it really does need to be fully captured. And I'm sure you'll show us what you did next, but definitely, not insufficient fixation or not fragment specific enough.
Yeah, absolutely. This would be a situation where I would say a fragment specific fixation would be appropriate, not a monoblock volar plate fixation. So I would have put in a ulnar sided fixation and a separate radial sided fixation, fairly distal, or you can put a distal, very distal plate. There are distal plates available, or there are specialized plates which will hold this fragment.
So people have written about this small volar fragment, and there are basically two subcategories. There's one that have dorsal instability, where we have a dorsal fracture dislocation where you pull off a small piece of bone attached to ligaments, and the instability is dorsal. And those ones don't seem to need as much volar fixation. And the ones that start volarly and go volarly, there's the ones that you need support in a buttress fashion. So you don't need many screws. You need something just to hold this thing up in a buttress fashion. And this is where maybe even if you had a wider plate to cover more of the lunate facet, you may need still to go past very distal to your watershed with or without screws in that piece just to buttress it up.
Yes. So now this was an old case. So this is an old plate. So this is the old
High plate.
pie plate, the Volar segment from the pie plate side, and we were able to reduce that. So that's
maybe before you go on to the next case, there's a question. Go back to your fixation, because I think this segues well into the question.
Yeah.
Jonathan Schneider is asking, is there a option, or what are other options? And Bert, feel free to answer too. If those fragment specific plates aren't available, either because you're in a certain hospital is just not there, or an AS, a surgical center where those plates aren't available for some reason, or even you're in another setting, another country where they may not have those plates. What are some other options? Can you use standard implants or K-wires even, or what's another good option for that?
Yeah, the other good options that I found with this fracture, a simpler option would be K-wire, like a unicortical tension band, or you can use one screw. If you have a washer or a cut up plate and use just the one screw hole, and use that and use a unicortical tension band. I have one more case to show that. And you can use those, or you can use just K-wires with a wire fixation that will hold the fracture fragment, and then supplement that with your Volar plate fixation if that's all you have. But essentially, my first choice obviously is a fragment specific plate.
I'd echo that. I mean, I don't even know that, I don't know how you found a pie plate, because I was probably the last person to apply a Volar pie plate in this country. And that was probably 2005. We can't have this set. So
Right.
I think that my choice would be to use a standard distal radius plate applied past the watershed line, understanding that I've corrected my Volar tilt, and the patient would have this plate routinely taken off at the 4-month mark.
Okay.
The other option, if you don't want to do that, is you can use these modular hand plates and you can curve.
Yes.
If you have standard 2.0 plates, you need something to buttress it, really. And
Yes.
all you need is something to go around the corner. Now, talking about specialty plates, Jonah, I'm not going to put in a pipe in for any special company, but there are many companies on the market right now that make these little extended thing. They can be a little claws that go in that you can bend. There are different.
Let me show you some things. Yeah. So this is just a illustration of another case which shows the fragment specific plates that were used to reconstruct a similar situation. And then I had this case. So this is that terrace corner that we're talking about, this Volar ulnar fragment. And that's what I call it, the terrace corner. So, and it is terrorizing. So this is the segment anatomically, and this is where the short radial lunate ligament is attached. It's a very thick ligament attached to the lunate, and the whole thing drifts forward once you break through that area. So it can be different sizes there, and you can see that it's very close to the watershed line, because that's where the FPL is lying there. And if you so this is where the fracture comes off, and then your plate, if you put it proximally, the standard Volar plates will invariably miss this. So what can you do? Any Volar plate, any of the Volar plates on the market, they'll all miss that ulnar Volar fragment. So there are many ways to deal with it. You can have these very distal plates. You can have these wire form fixations. You can have these specialty plates with the hook that Bert was talking about. So there are many options. There are other options which are, and I will skip through all this. There are other options which so here, as I was talking about, this is the fragment. You can see that it's like a boomerang. It's got a Volar part and it's got an ulnar part. It's like a boomerang, and the sizes can vary. And see, it's like this. Ulnar Volar fragment goes into the sigmoid also. And so you can put a plate from the handset. You can put a unicortical, like a cut up plate and take one hole and put a one-hole screw in there. That's like a washer, like this. Or you can take a tension band with wires, and there can many ways to fix this. So it's a complex problem, and something everyone should dealing with this situation should be aware of. And it can be very embarrassing if you miss these fractures.
You know, that was that was a fantastic bunch of slides, a collection. I want to say a little something about the tension band construct. So Jesse Jupiter was the first to publish on tension band fixation of that Volar piece. But the thing that didn't make sense to me is a tension band only works under tension. So it's
Right.
for those dorsally unstable fracture where that Volar piece is being held. The tension band doesn't work very well in a buttress mode. And I agree, I would use a small washer and a screw if you have any bone dorsally that's intact. Otherwise a screw doesn't hold. But the best thing you can do is you could take a quarter tubular plate, which is one of the flimsiest little thing that we have, cut off the distal hole and bend over the tine, just like creating a spring plate for a posterior wall on acetabulum, and contour it so the hooks are done there. And you can put a small screw, and you can in fact put a regular distal radius plate on top of that if
Right.
you need to extend your fixation. And that is probably the cheapest option to work there. They're very thin, and you can check on their floor to make sure their screws are not prominent. Then you've got a $150 solution for your disaster.
I think the important thing is to remember like basic concepts, right? This is a partial articular fragment, which is buttress, right? It's a B-type fracture. And so sometimes we get lost in all the locking options and all the different fancy new plates. But just like you said, a really inexpensive plate for buttressing is really all you need to push that and hold that plate up. And you can supplement it if there's other fractures, you know, with a more expensive or a more fragment specific or even a more sort of normal locking plate. But really for that fragment, you're really trying to hold it up just like you would for a proximal tibia, for, you know, a medial malleolus shear fracture, all those different types. And so sometimes we get lost in all the technology and all the new stuff, but we forget sort of those basic concepts. And I totally agree. I mean, we often use very inexpensive implants because you just apply the principles, right?
Having had patients come to me like this late, I can tell you they rarely do very well, even if they're revised. And I've had 2 patients that had to do a radiocarpal fusion because of a 3-month delay, and the lunate is now half chewed up because it's sitting on the corner of that plate. George Orbe wrote about this a few years ago in a paper in the Wrist Journal. And what he did, he thinks there's a bit of AVN when those pieces collapse. And he's treated this with an extension osteotomy of the distal radius to turn that volar tilt into about a 10 to 20 degrees of dorsal tilt to better seat the lunate in the dorsal side of that facet. So there are some salvage means, probably not for the basic crowd attending this lecture, but they can be very problematic. So those small volar facet fragments, I think you need to follow them closely in the postoperative period.
Yeah, I think I agree with you. The salvage is difficult, and if they've gone more than 4 months, then the cartilage is really bad on the lunate side, and they invariably end up with arthritis in that region. And then you have to do I do a radioscapholunate fusion myself. So, but I have done intraarticular osteotomies for cases that have come to me earlier than that. So that's possible, and they can give lasting results. But the salvage is the other option that you have to think about.
So just before we move on, Bert, there's one question in the Q&A about the role of X-Fix to back up this fixation. Is there any role for either of you for that?
I think there is a role. Yes, I think there is a role, and especially with the, once you've got the fracture fixed, either with K-wires or with a plate or buttress support, you can reinforce that, especially if the fragment is small. You can put an X-Fix or a dorsal plate, a dorsal Henel plate. Yeah, that would be an option.
I don't want to steal the thunder from Jonah's next case, but I would say that other than the study that we ran randomizing the older patients to external fixation, K-wires or plate, that I haven't put an external fixator on other than a pure soft tissue injury for the last 20 years. I don't think they control a lot of translation, Now, people of our generation, I mean, put a lot of external fixators on back in the day with K-wires, and maybe we're more comfortable. I would be doubtful that anybody in this panel would, they'd take around so long to try to figure it out. And I think in 2021, probably if you have volar instability, just like dorsal instability after fixation, it probably transfixing with a spanning plate would give you better stability of that
Yes,
fragment. That's
absolutely.
how,
That's
yeah.
what I would trade it. Yeah.
All right,
All
should
right,
we queue up the next case?
sure. Go ahead, Jonah.
So, um, so here's a case. So here's a 55-year-old man. He's a construction worker working at a construction site and fell about 20 feet off of a scaffolding. Ends up with the injury that we can see here on the right, and also an open left pilon fracture, a calcaneus fracture, and this very sort of contaminated left wrist injury. And I guess one of the questions I have is just seeing this and is, you know, Amit, what do you think initial management of this in the emergency department? Someone who's having this type of injury, what concerns you, and what would, you know, sort of change your management?
Well, obviously there's quite a lot of displacement, and what concerns me is neurovascular status. Obviously, it's in and the status of the wound that is present in this case, and
Yeah,
the
so he has a,
contamination.
yeah, go for it, sorry.
Yeah, and the contamination that that is there in this wound. Yes.
Yeah, so he has a an open sort of tension failure volar wound. It's about 4.5 centimeters, fairly contaminated. The whole arm is sort of covered in dust and in dirt. So, you know, basic stuff that you'd find at a construction site.
Right.
And, you know, he has well perfused fingers. I don't know if you asked about neurologic status.
Neurological, yeah, neurovascular
Yeah.
status, yeah.
He has numbness in the median region, but can kind of has a lot of pain, so it's difficult, but can sort of fire mostly everything despite the pain. And so, you know, he's in the emergency department. He has these other open wounds that, at least at our institution, nothing is going in the middle of the night. You know, this is going. He comes in, you know, I don't know, 4 or 5 in the afternoon. I forget exactly, but you know, it's coming in after. So, what's your management for this in Kentucky?
Obviously, obviously the management would be, antibiotics, and I would, in our institution, that would go in straight away and would get debris and get it fixed up. But certainly, do a reduction and try to hold it. Maybe put an external fixator if you can, and try to get the thing reduced and get a debridement going with the wound. Look at the neurological structures, look at the tendons, etc. Explore the wound and get a good debridement done.
Good. Yeah, totally agree. Bert, what is your feeling on the neurologic injury? Is that something that's going to force you to go earlier rather than later, or does that matter in this case?
Well, that would be my first concern. My first concern with this case is the soft tissue, the neurovascular status. I mean, I'd be doubtful that that median and ulnar nerve are both working normally. If they are, hallelujah. But I'd think that he's going to have some neurological findings in his hands, even post reduction. I think this needs to be reduced somewhat urgently. The cleaning can wait a little bit longer, but I would reduce this for soft tissue reasons as you would a dislocated ankle. And that's what I expect to see. And then I deal with the rest after that, understanding that he needs a washout. He needs a repeat neurological assessment. And this might be the rare case that if I had to go because it's grossly contaminated, other injuries, I may just X-fix this thing. Understanding I'm going to come back, I wouldn't leave an X-fix on at definite management. He'd have something else, but this may be the one case because of contamination. This is a soft tissue problem. I think the bony injury we can figure out later. And finally, coming back to neurological status, I think median nerve injuries are fairly common in high energy injuries. I know that there's a sense out there that some patients should be brought to the operating room if they got persistent median nerve symptoms. I think if they have a progressive changing neurological problem, usually associated with increasing pain, is you have a carpal tunnel compartment syndrome thing going on. And I think you should probably decompress them earlier rather than later. There's not a lot of hard evidence to suggest if you do it sooner rather than later, they're a neurological problem. But I'm thinking of more of the CRPS pain thing going on, and maybe there's a forearm compartment going on. But a static neurological problem post-reduction wouldn't push me any other way. The only question I would have is whether I would consider a concomitant carpal tunnel decompression at the same time of the open wound. This guy had a lot of swelling, and I would be worried about him post-op. I've operated on him. Now he's having increasing neurological symptoms. I got to take him back. So I would personally have a low threshold to releasing his carpal canal if there's clinically a lot of swelling and a neuroplastic injury, understanding that I don't have a lot of hard science on that. I don't know what, Amit, your thoughts are on these
Yeah.
neuropraxic injuries, if they should be released or not.
Well, this is widely displaced, and obviously you're going to debride that wound. So I would have, again, like you, I would have a very low threshold of releasing his carpal tunnel. No question about it. That would make me feel much more comfortable. And I can deal with the fracture later on. I would also probably put an external fixator, get the wound cleaned up, and come back to fight another day.
There are two
I
questions.
think it's a good point.
Sorry,
Yeah, I
go
was
ahead.
going to answer one of the questions.
Okay.
Yeah,
Go
so
for it.
I think generally speaking, if there's gross contamination, big pieces of dirt, rocks, whatever, we tend to get those out in the emergency department without sort of a very final or a very, deep debridement, just kind of clean the gross contamination out, maybe run a little bit of saline on it, and then bring them to the operating room for a formal debridement. And I would reduce them. I think it's more important to reduce them early, even with the potential risk of reducing some contamination, because when you take them back for the formal debridement, you will re-dislocate. You will go back and take all of those necrotic tissue, all of the contaminated tissue out. So doing a good early debridement in the emergency department is not doable for me. So I'd rather reduce them, offload the neurovascular structures, offload the soft tissue, get rid of the gross contamination, and then take them to the OR emergently, and then do that debridement there. So I think that's probably the best sequence of events for that.
Jonathan has asked you a question about immediate dorsal plate, and I think Jonathan will answer the question as we evolve, because you'll see what that happens. And someone has also asked about post-op, if we can get to that later, about covering the soft tissue defect. Are you a VAC guy, or are you a gauze and soak gauze with antibiotics kind of person? I guess maybe you can answer that, because you brought them to the operating room. I guess that was your next step, but you didn't image this thing anymore, I gather, because the patient had other lower extremity injuries that you were dealing with?
Yeah, correct. And so this patient was coming into the OR for other debridement. And so I guess I can answer that question two ways. One is prefer to cover the soft tissues depending on where the injury is, what are the underlying tissues, what's the underlying, is it directly onto bone, or is there neurovascular structures? Because I don't typically like to vac arteries and nerves and bone. That being said, there's ways to cover those temporarily with tissue in place of vac on. I think vac is very useful for a lot of injuries, but we just have to be careful because it can cause secondary problems. And so if that's the case, leaving it with either wet to dry dressings or some sort of dressing with either antibiotic, or we often use like a zero form type dressing, which is a laced dressing that's like an antibiotic gauze type of dressing. So depending on that, I think with regards to taking them to the operating room, if we were going to debride it, I tend to get imaging after initial pulling them out to length and reduction. Sometimes we're able to coordinate that before the OR, sometimes we're not. And so I can show you what we did in this case. I think it's going to be easier to discuss it, but I think, for me, the questions for this case are really, what are the various treatment options? And I think we've talked a little bit about them, and should this be staged? And I'd say, the upper extremity is a much lower risk of infection, but not zero. And so for those really contaminated wounds, I would, tell people to be careful nonetheless, with regards to putting a lot of metal or even doing it early. And if so, to think about how to do that, and specifically and especially in patients who have bad soft tissue coverage, because that's really going to increase your risk of infection. And for me, obviously, trauma surgeon at a big trauma hospital, I think the polytrauma impact is of premium importance for us. So I do believe that a dorsal spanning plate in this case would provide a much needed benefit for the patient to rehab early, to get up and moving again, not for the wrist obviously, but for everything else, and can provide really good length, or get the patient back out to length and provide that stability. So I can show you what we did, and at the same time we can kind of try to answer the questions. And this is, this is a different patient, just so you know, but I just thought it would be easy to show the setup this way. So after irrigating and really thorough debridement, which is much more important than just the irrigation, getting rid of all the contamination, then put the patient in a traction setup, kind of like this. So these are all sterile. The finger traps are sterile, but the string is sterile. And this is off the side of the table with a pulley system that has weights that you can add. And then it's really just to hold the wrist out to length. And then you can see this is sort of where the plate will go, in line with the second ray, and in line with the radius. We'll make a small incision proximally, small incision distally, and tunnel the plate under the compartment. And then I typically will fix, if I use this, the plate proximally, and then dial in the length and reduction with traction, and then fix it distally. And that'll give us the overall length and alignment. And then, as you can see in this case, we actually ended up fixing the joint with multiple K-wires, as they were very small fragments, and we were sort of weary about putting too much metal in due to the soft tissue injury. So just looking at the question, I think, there's one question about, do we involve plastic surgery early? And I think the answer, at least at our institution, I'll let Amit and Bert talk, is it's much easier to plan things earlier rather than later. If, some of our plastic surgeons are the hand surgeons taking care of these cases as well. And so the earlier you get people involved, the easier it is to plan eventual surgeries and subsequent surgeries, whether that's soft tissue coverage, whether that's other types of nerve injury repair or vascular repair. So I don't know, Amit, what do you feel? Do you feel like that too? Oh, you're on mute.
In Louisville, as has been the philosophy over the years, we are both orthopedic and plastic surgeons, so we can do everything. So I do my own flaps and soft tissue treatment and coverage. So we are in a good position in that sense, that I can deal with the bone, and I can also take care of the soft tissues. So in our institution, we do everything. But to this point, if you have, as Bert pointed out, this is a soft tissue problem, and the bony problem is secondary. So once you've done most important thing is to do a extremely good and nice debridement of this. You can do anything with the bone, anything with the soft tissues, once you've got a good debridement. So that's the fundamental thing. And the other thing I want to point out is that, Jonah has put in these nice K-wires to fix the fragments. Many times I see these dorsal plates being misused, but leaving the fragments not reduced, and just slapping on a dorsal plate and hoping that everything will turn out magically wonderful. That will not happen. So these dorsal plates are being misused throughout the country, and that's not the idea. The idea is to reduce the fragments and use this in a neutralizing mode.
We call that an OIF.
Yeah,
open
right.
mineralization, right? So I couldn't agree with you more that, you know, ever since Doug Hanel sort of published his paper on spanning plates, and those of us who have used it a lot have really found that this has been a very successful tool. I want to backtrack a little bit, Jonah, because I am sure for people who haven't used this, that you kind of put this in using a minimally invasive perk technique, and probably for a guy that fixes pelvises and pilons all day long, this is a simple problem. But I mean, I have my ways, but tell me exactly how you do this. What are the steps?
Yes, I think you know, typically we will do this in a minimally invasive way, and I think Doug Hanel, there's a, you know, the paper by Doug Hanel describes this quite well, of sort of doing a proximal incision, dissecting down, and then just going right down on bone, and then carefully elevating subperiosteally or even sort of supraperiosteally, and then sliding the plate distally in line. And I guess if you look at the alignment of the wrist, you know, that second ray aligns pretty nicely with the radius. And so as you slide that underneath the second compartment, you're going towards the metacarpal, then you make a counter incision, and you're typically able to go and grab that plate. And some of the tricks are, if you're not able to grab it distally, if you just dissect and elevate a little bit underneath, or sort of, again, supraperiosteally, the plate will be able to center, and then you can wire it distally and proximally until you get it in a nice spot under fluoroscopy. And then once you have that alignment, or the plate sort of well aligned, then it's a question of just stabilizing it. And typically you can do that proximally first and then pull it out to length distally, or distally first if it's a case where you're not sure where the plate will end up, as you might need to gain a lot of length, you know, depending on how much length it has to be gained. But that's why we like using this traction setup, because it kind of reduces it 90%, 95% of the way. And so the changes are minimal. And so that sets you up, and then you can wire it in place, and then put one screw proximal, pull it out, dial in the reduction distally, put a screw in distally, and then it's just a question of adding fixation. And so in those cases, I think that's, you know, just micro adjustment. There is a
So
question
Jonah,
about.
this is a plate. This is a plate that's designed for this, correct? And this plate design, I believe, has combi holes in it, and the distal holes are made to accommodate 2.7 screws and 3.5 proximally, or are they all 2.7?
2.7 distally.
2.7.
3 foot. Yeah.
Different, yeah. So that's kind of the usual market. I just want to come back to your technique again, because the traditionally, you know, we started off putting these plates on when we open up the wrist dorsally, typically through a fourth compartment. You've elevated the fourth compartment. You're like, oh my God, I can't fix this. And then we put a spanning plate. So you've got the fourth compartment opened. And for those of us who do elective wrist surgery, traditionally we fuse the wrist, putting the plate distally on the third metacarpal. And we know to dial in a little ulnar deviation. That means the proximal limb plate sits a little radial on the shaft. If you're not going to be opening up the dorsum of the wrist and you're going to do sliding a plate, you might as well slide it onto the second compartment, because you're not moving your wrist anyways. But for those of you who haven't done this, it's tight. That combined with a fracture, you're pushing this thing under the second compartment. I'm sorry about that. You're pushing this under the second compartment. And ultimately what happens is it's very tight. You slide it distally to put it on. So I guess for the people who work in smaller centers that you're looking for something and don't have this in their inventory, you can use a plate. The problem is most of the plates we have aren't long enough, and if you use a wrist fusion plate, it's too short. So you can use in a bigger patient a 3.5 plate bridged across it. Granted, the screws are big to do that, but typically that's very open. I would tell people to avoid sliding this under the third compartment, because it does add to the stiffness of their extensors and the digits. I don't know if you have tricks of the trade. This is a fantastically applied plate, but we all do it a bit differently. Has this been your preferred technique?
I use it very sparingly. I try to for very complex fractures, I try to piece everything together and really reconstruct the fracture. I use allografts, and I'll when I present the next case, I'll discuss this a little bit more. But I don't use this plate quite as much. Where I've used it are for dorsal carpal, for radiocarpal fracture dislocations.
Yes.
In those situations, yes.
So the radiocarpal dislocations, again, this is mainly a soft tissue problem, right? With a small bony
Yeah.
piece, and you want to hold the lunated line with the radius. I'd say
Right.
if you're going to use a spanning plate for a typical C3 fracture that you can't reconstruct, there are a lot of proponents to putting a volar plate on to act as a volar buttress, correct the extension deformity of the lunate facet, so you've got some platform to work with, and then bring the carpus down with a dorsal plate. So for those on this lecture, if you really have a C3 that you're trying to fix, you put a volar plate on, you figure I can't do this, it's a mess. You can leave the volar plate on as long as that lunate facet is somewhat corrected and add a dorsal plate onto it. That's not a bad way to go. The fracture dislocations rarely have a volar bony component, and it's usually a dorsal problem. And to me, it's the only way of holding that in place, short of putting a K-wire between the lunate and the lunate facet. Let's see what end up
So I'll just,
looks like.
yeah, so here's what it kind of looks like at the end after the case. And the one thing I wanted to talk about, because this came up in the Q&A, is sort of post-op protocol. Why would we use this versus an external fixer? And I can tell you at our institution, we will put these in a lot of patients that have lower extremity injuries. And depending on the injury, most of the time we will let them weight bear on this hand with a splint for transfers, platform weight bear with an adapted walker. And so it can be very useful for patients that have one or both lower extremities out to completely change them from going from, bed to chair on a slide table versus being able to hold on to something and lift up and manipulate themselves into a wheelchair. So it can make a very big difference for patient placement, but also for their, sort of early rehab. And so that's typically the reason why we do this versus an external fixer, whereas an external fixer really isn't stable enough and strong enough biomechanically to sustain those types of forces. And so because of time, I'll just kind of go through a little bit what the end result was. So here's the final sort of fluoroscopy after the plate was removed and the K-wires removed. We typically will remove those K-wires a little bit earlier, depending on how the skin is, how the patient is tolerating them, and how bad the injury was, and if there's any evidence of healing. And then the plate can be removed at 10 to 12 weeks, a little bit sooner if you plan on going back to doing more work, a little bit later, more 10 to 12 weeks if you're wanting to heal everything out to length. But at some point we do need to get them moving again. And so here's that final result x-ray wise. And then here's the patient at 1 year. Now, obviously this is not necessarily a typical type of result that you can get with these, but you can see that even if you immobilize the wrist for a not unreasonable amount of time, they can get pretty good motion. So that's the case. There was one last question about regarding dorsal wrist plates. Is there a difference in outcomes if they use the second versus the third metacarpal? And I think, Bert, you did answer that as far as stiffness in the fingers and in the wrist, but is there any other thing that you know of as far as that being studied, unless it's indicated for a fracture dislocation, something like that?
Well, I think it comes down to basically you want to have a hand that's collinear with the forearm. And we know that if anything, a little ulnar deviation is probably a good thing. That's your position of grip. So if your plate is sitting under the fourth compartment, it aligns better with the third. If you're in the second compartment, it aligns better with the second. I don't know that. Most people who put these things in perk put them in the index metacarpal, and people that are putting them open put them in the third. That's kind of a general consensus, and I'm not aware of any data for that.
Same, I would say.
That's a great case. Again, I'd come back to the same thing I put in the top 10. You can be very happy with the radiographic results and high five the crew on the way out of the OR, but you have a patient that comes out at 6 weeks, and just like his wrist doesn't move, his fingers don't move. these patients need a lot of attention to their fingers. That
Totally
was a
agree.
great case, Joanna. Fantastic.
Yeah,
Did you end up
very
releasing
good.
the carpal tunnel? Was that, did that resolve on its own, or?
We actually, we did not, and it wasn't a swollen thing. It was a pure neuropraxia. You could see the median nerve from the front. It just kind of, as you could imagine, it was stretched over the entire deformity, and so didn't end up getting a release, and partially recovered anyway. So yeah.
There was a question about VAC versus saline dressings. I mean, it's usually an institutional preference. If somebody has a wound that cannot be closed, are you a VAC guy or a gauze dressing guy at Harborview?
We're a pretty standard vac, unless, like I said, I don't like vacuuming directly over arteries because I've seen them erode through. And so I think the vacuum dressing is really good for maintaining sterility and keeping, the tissue alive and healthy. But unless you can cover the artery, even using specific sponges, there's different techniques. I'm a little bit more careful in those sense.
Amit, are you Louisville, or are you guys VAC?
Oh, we are not VAC people. and, and especially over the arteries in that region, we would not go for a VAC. I think we would just debride everything, and if need to, we would just do a regional or even a free flap,
Right. Okay.
depending on the patient's condition.
So let's move on to our last case, Amit. Let's see how far
Yeah.
we get in on this. And that was
All right.
fantastic, Joanna. Thanks. Great case. Classic Harborview.
Okay, I'll bring this. Okay, let's share this screen. Sorry. All right. So can you see my screen now?
Surely. Yep.
Okay. So this is a case. This is a 44-year-old gentleman who fell. We had an ice storm in February, I think. And he fell on the ice, and he's a non-smoker, very fit guy. He's a very famous chef and owns a very nice restaurant. And he came with a notable deformity of the wrist, but he had good range of motion of his fingers with normal gap refill and sensation. So he comes with this fracture. So he fell with all his body weight on the ice. Closed injury, 44-year-old. So, any thoughts on that?
Well, I mean, this is as C3 as it gets. I mean, it
Yeah.
doesn't qualify, I guess, as a fall from standing height. These younger patients that come in with a fall, I get concerned about bone health, but this sounds like a higher energy fall. Things that tweak my mind if I have a young patient fall from a standing height would be osteoporosis, and that stays in mind. But this is going to be difficult to reconstruct. It's got a very small ulnar lunate facet that I can see already. There's central impaction in the lunate facet. We can see both the AP and the lateral. And he's got the typical styloid, which is probably the most reliable fragment that can be fixed as one piece because it's probably less common. But I think the impaction extends all the way to the scaphoid facet.
And to complicate things, I was referred this by his friend, who is a very good friend of mine, Louis Schecker. So there's no pressure there, huh?
Well, if
maybe
he
question for
needs
you.
a distal radial ulnar joint replacement, he's got a good connection.
Maybe question for you from the audience is this typically always getting a CT? We did kind of answer that from the last one. And for those CTs, do you find the 3D reconstructions to be helpful or more causing more questions?
I think for me, for this kind of C3 fractures, I would definitely do a CT. And I think I would get a 3D reconstruction because that gives me an idea of looking at the geometry of the fragments in 3 dimension. I want to see the the central comminution, and I want to see the fragments going volarly or dorsally. As you can see on the X-ray, the volar fragment is a really small, tiny piece of volar fragment, but most of the action is towards the ulnar side. The radial styloid fragment is large. There's probably a central comminution here, but most of the action is going to be on the ulnar side, because you need to reconstruct the sigmoid notch very carefully here, because in order to give that pronation supination and to make sure that he doesn't get ulnar-sided wrist pain. And the height is going to be very important, because you need to raise that height so that you don't get you don't have any collapse. So I would plan to get a CT scan with a 3D reconstruction. So let's
would you do it post-production, or because one of the things we do in trauma a lot is you know, for pilons and plateaus and things like that is you can't tell as much when you're not reduced, or at least out to length, and it kind of looks a little bit confusing. So it's easy for us. You put an external fixator on, pull it out to length, and then get a CT scan. But for the wrist, it can be challenging. So do you typically have a trial reduction at least to get it more aligned and get more information?
I don't. I just get a CT because you know, this patient just showed up in my office and I got the CT that morning. So I typically wouldn't do that. I would just get a CT in the position that it is in. You can do a traction view X-rays when the patient's under block anesthesia just before you do surgery on that. And that may give you a little bit more information, but the CT itself with the 3D reconstruction, I think will give you a lot of info. So in the interest of time, let's go ahead and look at the CT. So here's the CT, the coronal views. And as you can see, it's pretty bad on the ulnar side and centrally. And there's a radial styloid is also split. And on the other view, and as I was saying, the volar fragment is small, but the dorsal fragments are very comminuted. So we'll go on and here's the 3 views which I've picked out. And the sigmoid, as you can see, sigmoid notch is really badly comminuted here. It's split into 2. And as Bert was saying, the split across the ulnar fragments into the 2 dorsal and volar segments, and the central depression with the radial styloid fragment. So any role for dorsal plate in this, Jonah?
Maybe. I think in this, this is reconstructible with plates and screws in my hand, with not likely needing a plate. I think you pointed the things out. I see that the whole concern is this guy's sigmoid notch. I can build everything up. Can I give him a congruent sigmoid notch and a reduced DRUJ? And I think this in my hands is going to need a minimum of 2 type of devices, with a radial column plate and a dorsal plate, or a volar and a dorsal ulnar corner. That's what I'm seeing. And I'd have a bailout for me would be if I'm getting in there volarly, and I'm going to fix that volar lineate facet fragment that's extended regardless, because there's no traction in the world that's going to reduce that. So that would be fixed. And if I thought the rest was mush, I'm going to open them up dorsally regardless. I'm going to look at the joint. I'm going to piece all these things back together and try to reconstruct that joint if I have to hold it with K-wires. And I'm probably going to finish off with volar to dorsal screws, buttressing my reduced piece. And it's going to be probably an additional dorsal ulnar corner to hold those pieces that my volar plate may not be able to get. That would be my working plan on this guy.
Yes, absolutely. So a very important thing that you mentioned was that this is not something which is, you know, I don't think in my hands, not amenable to fixation with the volar approach only. You have to look at the joint surfaces And I think the dorsal exposure, opening up the joint would be appropriate in this situation. So, and I would have allograft ready because you
Yes,
need to have bone grafts, and I use allograft.
I do too.
Yeah. So let's. So this is the 3D CT reconstruction, and as you can see, huge central depression there. So I usually start with reconstructing the styloid. So that's my first thing. So I start with the reconstructing the styloid, and I'll, as Bert mentioned, we'll put lots of K-wires, look at the joint surface and reconstruct that, look at the sigmoid and reconstruct that. And what I did was I fixed the styloid with K-wires, fixed the ulnar volar fragments with K-wires, then came in and put a radial styloid plate. Then I put an ulnar plate, and I put the screws from the dorsal to the volar side and compressed the fragments so that I could reconstruct the sigmoid notch and hold it in place. And then there was a dorsal fragment which I kind of tension banded with the 2 K-wires, and I plan to take these out, and this particular played out very soon. So at this, once this was done, and lots of bone graft to buttress the central portion, I had a absolutely beautiful joint reconstruction when I finished. So when this was done, and that's the lateral side, as you can see, holding this, I've compressed the volar fragment with the screws here, and so this is him at 3 months, and at 3 months he's got full range of finger motion, full range of shoulder motion, and he's got 50-50 and full pronation supination.
Amit, how did you reduce the volar lunate facet fragment from the dorsal side?
Okay, so what I do is I looking at the volar side, I put a finger on the volar fragment, lifted it up, and then I put a K-wire like a joystick,
Yes,
from proximally distally, and held that, and then put the K-wire, 5.4 or 1.2 millimeter K-wire, and tilted the fragment up. So I reduced that fragment, and while holding it tilted, then I put another K-wire directly across from the dorsal side, and then I compressed it with a plate.
so I think it's key to understand that, and we all have our little things that we're very dear about. That volar lunate facet fragments always collapses into extension deformity, and it's very hard to reduce just pushing on it because it pushes on to more extension. So if you're on the dorsal side, you open up the door like a tibial plateau, right? You take out these bilateral fragments, and you put a K-wire and you force it into flexion. You can usually see on their fluoro that it matches the contour of the lunate. And for those out there, people who do general trauma, it's like when you start pounding up the cartilage from the lateral plateau, you can't see anything anymore. That's usually the good sign. So the problem is once you've lifted it up, I find you need to put another K-wire from someone else to hold that fragment so it holds together as you close the door dorsally and able to plate it.
Yeah, so I think it's very important to use that corpus to reduce the very complex fragmentation of the distal radius. And then you can put K-wires through the lunate into the fragment to hold it in place. You can do that, and keep the reduction that way.
I mean, this is a really nice reduction, nice result. Maybe you can chime in on a couple of questions from the chat. So
Sure.
One of the things is, Rick says, this is not an uncommon scenario in elderly patients in his practice. What are some pearls that you might say if this same patient, same type of injury, but with osteoporotic bone?
Oh, in that situation, I would certainly think about putting a dorsal spanning plate. And I would use the K-wires to hold them. And if the fragments are very porotic, I would have no hesitation using a dorsal spanning plate.
Okay, and then both of you talked about bone graft. Bert, is there anything that you would do differently for really bad osteoporotic bone? And I'll give you an example. Like, do you think calcium sulfate, calcium phosphate, cement? Is there anything that may be more structurally sound than bone graft?
So based on somewhat weak evidence and cost, our center has gone to allograft chips for most fillable defects unless we want to deliver antibiotics, be that in the tibial plateau and the distal radius and the proximal humerus. And we just take the cancellous chips and pack them in there as a bit of a raft. We've gone away from calcium phosphate. I just don't like the mess it makes, and there's some question whether it causes osteonecrosis of some of the fragments. So we've gone around with that. Cement, PMMA, I've never used it in the wrist. And I think these holes are too big to fill up with cancellous bone. I just want something structural. So just like, and these rarely impacted, we're able to get these things in 15 cc's now. They only can take usually about 5 cc's, but that would be a defect filler. And again, it's rarely used. It's mainly used to support the lunate facet impaction. I wouldn't use it in somebody who had a very comminuted metaphyseal segment from a typical Colles. It's really this punched in lunate facet, because at the end of the day, I want to have my sigmoid notch back, really. That, you know, all the patient's problem is not going to be likely related to what's happening in the scaphoid facet. Even if it's impacted or slightly malreduced, it's going to be about the sigmoid notch, and it's going to be about getting the length of that ulnar corner of the sigmoid notch level at least with the ulnar head to restore tension on the TFC and then minimize impaction. So my money is all on that corner. The radiostyloid piece is adjuvant.
Okay. Well, specifically about that, you know, somebody asked, do you place this radial styloid plate directly under the first compartment? Is there a risk of tendon injury? Amit, what do you think?
I have not seen that. What I do is I take the brachyradialis off, and once you take the brachyradialis off, you basically decompressed your first dorsal compartment. You're lifting the first dorsal compartment. Many times, I love this radial styloid plate, and I'll use the radial styloid plate from the volar side because the styloid is anatomically volar. So it's easier to place the styloid plate from the volar side. So you can use the styloid plate both from the dorsal and from the volar side, or you can do a direct radial styloid incision and place the styloid plate in that position. I have not seen any problems with the tendons, but then I tend to take them out. They can cause tendinitis. And if they feel, I tell the patients, if they feel like something like a saran wrap under the skin, with a crinkly type of sensation, that would be tendinitis. Then if that happens, I tell them to come right back and we'll take the plates out.
Okay, and then can you just comment on the order of fixation for this type of case? Is it, did you go medial first, lateral first, or sort of ulnar first, radial first?
I always go styloid first. I get my styloid aligned with an indirect reduction so that I have a good standard. So I go styloid first, then I would lift the central compression and then pack that with bone graft. Then I spend a lot of time on the ulnar side to fix the ulnar fragments. So because that's the most important thing, as Bert pointed out. So I will make sure that I've got a very good reduction on the ulnar side, both direct and indirect, so that I know that the sigmoid is fixed. And then I look at the X-rays in different views, look at the sigmoid notch with the hand pressed against the X-ray machine so that I can get a good view of the sigmoid as well as getting a view of the joint. But I'm looking at the joint line anyway on the, visually. But you need to get a good height reduction, and you need to make sure that the sigmoid notch is well reduced and make sure that the distal radial joint is stable.
I have a little different take. My perception is that hand surgeons love volar radial plates or like them more often, and trauma surgeons don't. It's kind of a, this is a dichotomy in groups. I think that if you're good at a radial styloid plate, it can be good, but there's lots of problems that can occur. I mean, there's a radial nerve is right there. The branches are there. And even if you just put too much traction on them, they get a neuropraxic injury. The first compartment tendons go from a dorsal to volar direction. And in my case, I have to release the proximal half of the first compartment to slide it, because then the the plate, the tendon start covering the plate, and I do much less radial styloid plating than I used to. I think the indications for this in my hands would be impaction of the scaphoid facet. I don't have any other way other than K-wires of buttressing, of rafting that scaphoid facet, unless I have screws that come from radial to ulnar under that facet. And the second reason would be if I'm planning on plating the dorsal-ulnar corners, I got to go there. Instead of going volarly, I may do a radial column plate. And as you can see, Jonah, in the question, someone asked, can you put the radial plate and the dorsal ulnar plate through a same dorsal incision? Amit, do you have what is your preference? Do you make a
From
separate?
no, I don't. I very rarely make a separate incision. If I'm gone ulnarly for a fragment specific fixation, dorsal ulnarly, and I'm putting a dorsal ulnar plate, and then I'll put a styloid plate. But if I've gone dorsal central, I will take out the brachioradialis, release the first dorsal compartment, go from the radial side. So I'm very deep. I'm on the bone itself. So I'm coming nowhere near the dorsal sensory branch of the radial nerve. And so I can put my plate in that position very easily in that situation. If I'm going from the volar side, the radial styloid is almost there. I mean, it's volarly, and it's very easy to put the styloid plate in that situation.
I agree. I prefer the volar incision. It's way away from my nerves, and I can go if I'm a little bit. I go with the FCR, and if I need to go ulnarly because I need to basically reduce the volar lunate facet fragment, I'm there already, and I just elevate a skin flap and put it under the column, and then I'd make a separate incision for the dorsal side. I don't know, Jonah, if you have any tricks in the trades of approaches to the wrist.
I tend to do just like what you described, Bert. So like I go and just lift up and go volar. I'm able to get pretty much everywhere around there, and I'm just trying to answer a lot of the questions in the chat. A lot of them focus on that. I think one of the things that come up is how much fixation do you need in the radial styloid? And I would say, it depends on the fragment. It depends on the size of the patient, but typically you want at least 2 points of fixation for rotational stability. And if you're putting a plate on, then a buttress, with at least one screw going through the distal segment. If you're just putting screws or fixation, supplemental fixation, then I would say probably want at least 2 points of fixation to avoid any type of rotational deformity.
Okay, I'm gonna try to briefly go over. Are there any other questions, Jonah, from the chat? There are a few things that are there. Did you want to? The volar lunate facet fragment does not look supported here. You mentioned K-wires. Does this hold up long term? The K-wires that you put in with the tension band, I guess those are provisional, correct? You're going to take those
are
out?
provisional. Yeah, I'm going to take them out next week. Yeah.
Okay.
And then another question maybe for both of you is very quickly, like what is your specific indication, sort of not 100% indication, but what's your most common indications for going dorsal instead of volar for distal radius fractures as a general rule?
C3, extremely comminuted fracture with a central depression. I talked to Orbe. George says that you can deal with almost all cases from the volar side. And there are instances where you can go with an extended exposure, where you can rotate the proximal fragment out and you can lift the central depression also, graft it backwards, and then reduce everything from the volar side. But in my hands, I think I need to see the dorsal, I need to see the joint surface. I need to see that I've accurately reduced the articular cartilage. And for that, I go dorsally. I'll even make a small incision and open it dorsally just to look at the joint, make sure that I've got everything, even though I put in a volar plate. And that gives me the opportunity to actually release the EPL and transpose it out of the way too.
So I would echo that. There are two indications: impacted articular fractures that you can't reach from the volar side, And dorsal fracture dislocation, it's going to likely need some type of bridge plate. I don't often go dorsally. I will accept a certain amount of impaction. I'll try to get it from the volar side if I can't. Even if I can, I go dorsally. So that, and usually if I'm going dorsally, it may imply that I'm going to put a plate dorsally as well. They kind of go together.
All right. Just for time, do you want to go through this?
Sure, I'm going to do this. This is going to be 5 minutes. We're going to shift gear. We're going to talk about some question about lower demand patients. I just want to take 5 minutes to talk about this paper. I was involved in one of the multi-center studies that Kevin Chung did. It was the risk study where we had multiple centers looking at outcomes in patients over the age of 60 years old with multiple different types of fixation. This is a big brother paper of the small sister, small brother. This is a 12-month outcome that was first published in hand and peripheral nerve, and the 24-month outcome was recently published. It was presented at the OTA by myself this fall. This is a risk group. The purpose was to compare the patient-reported outcomes at 24 months in patients over the age of 60, treated either surgically or non-surgically, and a surgical group was volar plate, K-wires, or X-fix. X-fix could have had a K-wire versus cast mobilization. These are patients over the age of 60, tape A1, 2, C1, C2. Notice there are no B fractures. Coming back to Mitt's initial case, to me, all B fractures should be fixed, regardless of your age and demand. They all do well. Radiographic parameters were put forth that kind of with the typical exclusion. I just want to get through this. So patients were talked about the study. They were consented for surgery. If they elected and they were okay with proceeding with surgery, they were randomized into one of 3 limbs. We saw them 2 weeks, 6 weeks, 3 months, 6 months, 12 months, 24 months. These are the 3 options. Plate, volar plate of your choice. X-fix with or without K-wires and K-wires alone. We looked at Michigan Hand Questionnaire scores. We also looked at grip strength, range of motion, SF36. These are the numbers. We ultimately randomized 187. And the patients that didn't want to have cast surgery, we had them in an observation group to compare, and those are the cast mobilization 117. And you can see below the division between the 3 various groups. What we found, and this is not new, but reinforces what we saw, you know, at 6 weeks, the volar plate group did better than anybody else, although on the graph, it doesn't seem much, but they were statistically better. And those differences did not exist after 3 months. So by 3 months, they were about the same. Now, these were all comers. The worst patients were the external fixator group, and they remained bad till the end. They were worse significantly at 6 weeks and 3 months. I know this is probably information that's over everybody's head if they've only been in practice for 2 to 10 years, because nobody does this anymore. But there is still a subset of surgeons in the world putting external fixators on patients with osteoporotic related fractures. The pain treatment, again, volar plate was better throughout the whole first 6 weeks and 3 months. The results basically were same for all the domains. 6 weeks, best scores for the volar plate, worse for the external fixation. No difference after that. We looked at grip strength. Now this is interesting. Grip strength better. 6 weeks, 3 months, up to 6 months with the volar plate. So the volar plate does confirm better grip strength even beyond the 6-week mark in this group. Basically, I'm not going to talk about range of motion. I want to get basically to the point. We looked at all these. If you look at 12 to 24 months, and this is not discussed very much, is there was no change in the primary outcome, the Michigan Hand Questionnaire, but all patients had significant improvement in the pain questionnaire and their grip strength and range of motion. Good data to take your patients that if they're doing okay at 12 months, expect improvement up to 24. And this was a significant difference. Malunion by treatment, no difference. If you looked at the cast mobilization, well, no, significant difference, but not by outcome. So the cast mobilization had significantly more malunions, but if you look at the outcome, there was no difference. So malunion would be the lighter green and the no malunion would be the dark green. You notice that their summary score and MHQ were no different. So a malunion does not confirm a worse outcome. The strength also all comers, not difference at the 24-month, whether you had a malunion or not. Motion was the same. Conclusion is recovery was fast as with volar plate and slow with X-fix. Not a surprise. In most cases, no differences by 6 months. So casting participants experienced satisfactory result despite loss of radiographic alignment. Grip strength improved from 12 to 24 months. Range of motion improved from 12 to 24 months. And the volar plate provided the greatest impact on strength for 12 months. I'm going to stop that there because there are 6 other papers that came out of that we can discuss. But I think there's a growing belly of evidence to suggest, age is, we all know that probably age is not cut off. It's really activity. So if you have a low functional man patient who's 75 years old, doesn't really do very much, that your result will be the same with a cast. And I think this is information you can share with the patient. I personally have a lot of problems. I have more problems not treating elderly patients because, when you take the cast off in clinic and the daughter and granddaughter is there and the wrist is all crooked and they've got pain, it's a long discussion that you need to tell them it's crooked, but it's going to be okay. And I think this discussion needs to be held off the bat. I think there's a lot of evidence to support that if you have a patient that's higher functional man, their grip strength will be better. Probably if you just took out that group, and that's one of the papers, that these patients are significantly better even at 12 and 24 months in data, if you tease out the patients that are higher functional man. So I think this just adds to our inventory of knowledge about management of these patients that can have terrible malunion. The one caveat I want to remind you is there's really no role for volarly unstable, volar shear fracture treated non-operatively, even in the elderly. They do terrible and they have very significant loss of supination. I know, Joan, at Harborview, you probably don't see a lot of 65, 70-year-olds with isolated wrist fractures. And if they are there, they probably go to the hand service. But do either you or Amit have any comments on the management of these patients?
I mean, I think because Amit's moot, I'm gonna be able to talk first. Haha. I think just like everything, a lot of studies come out with op versus non-op, and the question is how do you extract that information to apply it to your practice? So I think you did a good job of highlighting that. I think just be wary. A 60-year-old is not like every 60-year-old. Steve Benershka is one of my partners. He's 68, and if I casted his displaced distal radius fracture, we'd never hear the end of it, right? We'd have to fix it. So I think it's, literature is very useful and it allows you to understand and interpret it and then apply it to the patients. It gives us some backing when we have those discussions. But I think ultimately applying the knowledge that we get to each individual patient is probably more important. So just like it was for the proximal humerus fractures, I'm a proximal humerus fixer. I talk to the patients, say this is what the literature says, but also this, and then you can make the right decision for that patient. And just important not to blindly apply those lessons.
Well, my partner was involved in this study group, so a lot of our patients from our group are also in this study. So I agree with your conclusions, but then I agree with Jonah that you have to assess the patient and see from the functional point of view. I just had a lady, I just took a cast off today. She's 85. She's low functional, and I chose to, treat her non-operatively. She collapsed a little bit. Height was not maintained, little deformed, but she has excellent hand function now. So, we know from past experience that, in the elderly, a lot of these deformities are well tolerated, but it's not so in the young functional patient. So you have to assess it. And I think I have regretted not operating on people who have had a little collapse, and then you end up with doing 4 operations afterwards, trying to get rid of the distal radial joint pain. So that's not fun. So I would say we have to assess each individual patient and the fracture and the personality of the fracture and treat it accordingly.
I agree. I think that, people have come up with the scoring system, one of them, the RAPA scoring system, which basically is a checklist that puts your patient in a certain category of activity rather than age. And they have the inert or inactive patient, moderately active, highly active. And this is a little bit of a checklist, RAPA. If anybody want to Google this, you'll find this checklist. And it may give you a bit of better objective decision-making on choosing your lower demand patient. certainly the 85-year-old woman that comes in on a walker with her daughter is probably a candidate for non-operative treatment. The two things you have to tell them is, yes, you need a cast, B, it will be crooked, and C, it will get better. I guess that's three things. But you have to preempt them about it. And often the family would say, thank God I don't need an operation, but you'll have the patients that said, listen, this has got to be straight. And I think you have to listen to their wishes. We just have more evidence now to be able to share our decisions with the patient. Listen, we're just about 90 minutes, short of 2 minutes. Is there anything in the Q&A, Jonah? You've done such a great job with that tonight that we have to bring up.
Just one last one. Any difference between dominant and non-dominant after ORF in that wrist trial?
We didn't notice that. We didn't stratify them by dominance. So that's a good question. I think that I would add that to the list. I personally am a plater, and I find it's a lot easier. It's a 30-minute operation and a patient to put a plate on. I don't even put a splint on them post-operatively. They have a loose dressing. They can use their hand as tolerated. They can use a walker. I have no limitations for them. Because I do a lot of fracture fixation in the wrist, but ultimately if I ding this person's median nerve or I put the plate on the wrong place and cause a complication, everything I've tried to do is lost. So we have to keep in mind that, after all, complications do happen. So a dominant hand would probably lean me to be more aggressive.
And then someone wanted to confirm the name of the checklist. It's the rapid assessment physical activity, right?
Yeah, RAPA score, and there's two parts of it. And we're currently looking at that in some other studies, is trying to, instead of define somebody by age, it's a questionnaire you give to them, and it's a pointing system that you get, and trying to correlate RAPA with outcomes and see. And this is just another measure of trying to look at activity level. Well, listen, with all that being said, I want to thank the both of you for the fantastic cases. I hope the Fireside audience has had as much fun. I like to thank AO, Mitch and Brett for driving this. Welcome you back to the series that occurs every Tuesday night. You will receive some email correspondence. I'd like to thank Candace and Mackenzie for the time putting this together. And I wish you all a good night.